Good afternoon, Dr. Lee and Professor Lee and everyone. I'm Dr. Xin from Linkou Changgen Memorial Hospital from Taiwan. It's an honor to have a chance to present our findings and thoughts about the application of drug-induced sleep endoscopy in our service. And I have nothing to disclose for this talk. As we know, Dise drug-induced sleep endoscopy can trace from 1990s. From UK, Dr. Croft and Prendel, they used the midazolam as the sedative agent to evaluate the patient's sleep airway. And then it developed for 2 decades, more than 1 decade, and to Dr. Parisian, which is Eric, which is very famous of setting up the Dise nomenclature. It's the most used classification system now. But for the application still under debate. Today I'm not going to cover everything. I will just briefly introduce the way Dise is conducted from the pediatric aspect and the adult aspect. As we know, if you are familiar with Dise, you will be criticized mostly. It says, okay, it is useless. Why do you do it? You don't need it. And if you're not doing Dise, you might think, okay, according to literature, yeah, you don't need to do Dise. You just to do the clinical assessment and do the surgery and see how it goes. But if you are doing Dise, then you might think differently. From the pediatric aspect, what and when do we will do Dise? It depends on how do we diagnose the patient and make the decision tree. Normally, we can figure out the treatment protocol from the physical examinations and the symptoms. And some of the patients might need polysomnography to confirm our diagnosis. And most likely we do the surgery. Most likely we can successfully cure the little patient by tonsillectomy with or without adenoidectomy, or vice versa. Then the children may become symptom-free. However, there are several patients, as you have encountered more and more cases, you will encounter those patients who were not able to be cured by single surgery, TNA or adenoid alone. You don't know where, you know that the patient is obstructive, but you don't know what type of obstruction it is. So this is maybe the time we perform Dise. So in our practice for primary Dise, sometimes we have to decide whether or not the patient needs to do Dise or not. Most likely is from the treatment failure patients. And let's see the evidence, what the evidence says. From the most recent meta-analysis of the children from Dr. Wang, performing Dise over the pediatric population, most likely we will result in a treatment modification, including originally we're about to perform that adenoidectomy, we might add as a tonsillectomy during Dise. And the basal tongue surgery range from 9 to 22%, and the supraglottoplasty ranging from about 12%. And however, there are some differences need to mention is the way the protocol. How do you perform Dise? It depends. Maybe sometimes it's affected by the medication, sedative agent use may contribute to this finding. And of course, it's not randomized study and lack of control group, but this is what we know. We can directly see a case. A case of mine is a 3-year-old boy who was complained of, brought to our clinic by his parents of a poor sleep quality. And from PE, we have performed PSG, and he has a 6.7 HI with a moderate obstructive type with that lowest saturation 66%. So his lateral skull show only 20% of adenoid hypertrophy, and clinically his tonsil is only grade 2. So it is very challenging that if we perform, will it be effective if we perform TNA? I don't think so. So I primarily perform a Dise for this kid. So if we observed is a very significant obstruction and slightly desaturation. So this plan, the patient has underwent a tonsillectomy and supraglotoplasty. We resected part of the supraglottis, and the patient become asymptomatic. His clinical condition dramatically improved after a month of surgery. So his parents are very satisfied. So from this case, you can know there are some, not all the kids need a Dise, but some of them you have to, it is very crucial to make a correct decision. So the challenge is because how the medications are done, and do we have oversedation problem is not answered right now. And now we go from pediatric to adults. For adults, I think in Taiwan, we have most of the patient, we ask the patient to do, if it's too much obese, then we suggest the patient go on a good diet, a good body weight reduction. And for others, we encourage them to try the CPAP titration. If it's stable, then it's not of no surgeon specific, right? But for those who fail from the CPAP, we have to decide, before Dise, we have to decide, okay, what is the anatomic findings for the patient? And it is related to how do we surgically treat the patient. If the patient, after surgery, if it's symptom-free, then it's okay. But if you are really doing the sleep surgery, you will know most likely, often the treatment is not so successful. So we have to know, okay, if it's failed, we have to do Dise to see, oh, what went wrong. And sometimes it's performed by our colleagues and referred to us. So whether or not we need to do the primary, we needed to be more aggressive to perform Dise for every patient, or we only perform those for the failed patient. It remains discussion. But for me, I would like to suggest every patient, except for the huge tonsils. If your patient has grade 3, grade 4 tonsils, he might be treated successfully just by soft tissue surgery. But except for that kind of patient, he might benefit for Dise. So the evidence tells us, okay, Dise may change surgical decision and from the tongue-based and hypopharyngeal obstructions, and we may identify residual obstruction. But the same as pediatric ones, the protocol is not standardized. The way of sedation, the medication used is differently, and the classification system varies. However, now it's more likely we use the both system. It's more comprehensive. It's easy to do, and the surgical, according to literature, different studies use different surgical outcome protocols. The surgery is different, so it's very hard to say if Dise is really helpful. Does it really help to make the correct surgical decision? Does it really make the more likely to surgically success? We don't know. So in short, okay, there's no consensus of the effectiveness of Dise improving surgical outcomes. So now we've done a little bit of venture here. It's now still not conclusive. So in our practice, we developed, Dr. Lee and I developed the interventional Dise. We want to see, from a surgeon's perspective, during the Dise operation, the inspection, if we add some spice, add some maneuvers, can we know more about the physical, the anatomy, the changes over soft tissue while the patient is induced sleep? So we have several protocols. We perform a jaw thrust. We open the airway by lifting the jaws, so we can observe if the patient's airway is more open, or is what changed about the patient's, and about head rotation for the positional change. For this patient, normally the airway is totally obstructed. It's obviously a B2 patient. Okay, the video is. Dr. Xu will expand this topic later, so please jump to the next one. So for us, we add the third maneuvers. We use a needle to hold the soft tissue at the center of the soft palate, so we can lift the valent. We can relieve the valent obstruction during the phase. So from the patient, we can change the V2 from Vx that is not obstructive, and we can see what will happen. So this is the patient that we're performing the anterior displacement. So originally you can see it's a snoring patient with the total obstruction of the V2. The snoring is very loud. After, we pull the valent anteriorly. Okay, now the snoring is gone. And we observe that now we can make a second vote system. Now we can see the tongue base, it's very stable. The snoring is gone, and the desaturation is gone. So this is the change of the anterior displacement of the valent. So what happens after the anterior, we relieve, after the relief of the valent obstruction? So there are some possibilities. We have a V2O2, which is normally we will refer as a complete concentric collapse, which is a pretty bad condition. And after after VAD, we do the anterior displacement. We can see the left side is no advancement, right? With advancement, you can see the snoring pattern also change. If the soft palate is pulled off, there is no obstruction here. Some patient will develop a second collapse over the epiglottis and a secondary snoring over the hypopharynx. That may be the part when this kind of patient underwent UPPP but failed, still have snoring, which sometimes is very troublesome for the surgeons. So look at our data from 2021 to 2024. We have 144 patients underwent the Dise surgery preoperatively. We can see the valent. Most of the patient is concentric collapse, and most of the patient had V2, of course, because they come to the sleep clinic, they have suffered from OSAS. And you can see this is before the neutral position, and this is an anterior displacement. On the neutral position side, most of the patients are O2 on the oropharynx level. They are total obstruction and partial obstruction, and almost every patient is a lateral collapse. And after the displacement of the soft palate, the total obstruction decreased to only 18. Like it has been shifted from the total obstruction to partial obstruction and partial obstruction to no obstruction. But for the tongue base, it does not change that much. And very interestingly, there is an increase of the epiglottis. So you can see from this, this is a patient with a loud snore. I talk too much during the surgery. So you can see the obstruction after the anterior displacement right here. You can observe there is the snoring pattern has changed. Sometimes it disappeared, but sometimes you can see there is an obstruction of the epiglottis because the relief of the probably because the relief of the valent, the increase of blood flow, the airflow caused the epiglottis to become sucked in. So you can see after, this is the oropharynx. I'm sorry, this is the oropharynx. Normally it's total obstructive. Now it's partially obstructed, and the tongue base doesn't change a lot. And for the epiglottis, just like the two videos before, some patients increase their epiglottic collapse after the valent obstruction has been resolved. Okay, so finally, there is one we can see. We already know that complete concentric collapse is a very poor prognosticator for soft tissue surgery. But since it is secondary to valent total collapse, so if we can successfully control the valent collapse, that means the CCC is not always a poor prognosticator, and it is compatible with our findings. And for this tongue-based collapse, there is a very high chance. So we have to more aggressively treat this type of patient. And for epiglottic collapse, it is if you don't perform Dise for this patient with anterior displacement of the valent, you might not discover, because in the neutral position, it does not happen. Only from the opening of the valent successfully, some patient will discover the collapse, secondary collapse of the epiglottis. That might contribute to further snoring sound at the level of hypopharynx, or more obstruction that you're not able to figure out. So back to this, when other people said, okay, Dise is not as effective, I might say that is your Dise, not my Dise. So improve the quality of the Dise, maybe answer more questions clinically. Okay, that's my talk today. Thank you.